Hello, everyone, and welcome to the TRT and Hormone Optimization YouTube channel. My name is Danny Bossa. I'm joined today with Gil. How you doing?
Doing well. Thanks for having me on again.
Great. Gil is a director at multiple men's health clinics. We can call him also a biochemical researcher, if you will. Extremely knowledgeable. You may have seen it on the video we did last week with Dr. Jordan Grant. A lot of people really appreciated that. So Gil had the idea of doing somewhat of an interview where I would pretend to be a patient that comes into a clinic that has zero understanding of TRT. And yes, I know you guys are going to make all kinds of jokes in the comments about that, but just for pretend.
Do you really have to pretend?
I don't really have to pretend, yeah. Danny's not pretending. So I'm going to just come in and say, like, I'm just going to ask questions. If I was a patient, zero understanding of TRT, what would I ask my doctor? And I can try to think of some of the stuff I asked back then, even though back then I still had some knowledge, but we're going to go in as the most naive, ignorant, and I know the jokes are going to come, patient possible. And we're going to let Gil try to explain everything in as simple English as possible, try to cover all the bases.
Welcome to this channel. I am Dr. Steven de Vos, the lifting dermatologist, and this is my partner Danny Bossa. If you want to learn more about the most cutting-edge science-based information in the world of hormone optimization, please like and subscribe. I also invite you to join my other YouTube channel, The Lifting Dermatologist. The link you can find in the description of this video.
Okay, so Gil, I'm coming into your office. I'm probably embarrassed that my testosterone is low. And I've got maybe ED, and I got poor libido, and I don't feel well. Probably the poor libido and erections will probably make a lot of people a little embarrassed and hesitant to walk into the doctor's office to begin with, even to discuss such things. Okay, so I'm sitting down in the office. You're there. There's other doctors there, perhaps, and they're like, "Okay, Mr. Bossa, what seems to be the problem, right?"
Yeah. So let me preface this with, this is going to be far more in-depth than what we actually do in the office. Yes, we like to educate patients. It's important. I'm a big advocate of patient education over the course of time. People walk out with too much information. They walk out confused, and they kind of, put up their guard and shun it all out. I like to give them bits and pieces of it. Basically, the macro picture of what is testosterone, how it's produced, why you're lacking it today, perhaps, and how do we fix this? And then as an ongoing process of the treatment, they're going to ask a lot of questions. We're going to be doing lab reviews. We're going to be following up on more information. So I just want to preface this because people are going to kind of see this video and say, well, is this what I'm going to be doing in the office? No, this is not a typical consultation. This is essentially, think of a semester's worth of a college course as opposed to one lesson, right? So this is going to be far more in depth. Oftentimes people think that there must be a sexual dysfunction for low T in order to go in and get checked. And that's just not the case. I've seen guys with severely low T. I mean, I'm talking in the 100s on the total, low single digits on the free, and they have no erectile dysfunction. They have no libido issues. This is not an all or none type of a symptomatic umbrella, so to speak. This isn't like, I do have energy and therefore I don't have low T. I do have good erections, therefore I don't have low T. That is not what this is about. Testosterone regulates so many mechanisms, all right? It is the predominant male sex hormone. And the word sex often confuses people, but sex in this case means gender. It doesn't mean, the sexual activity. So it is what makes a man a man. It is what gives you a deeper voice, makes you more muscular, stronger, more aggressive, that aggressive personality, that protecting personality, that hunter-gatherer, primitive personality that men have. That is what testosterone does for you. And when you start to lose that, you're not just losing your male identity, you're losing a lot of your health, a lot of pathological changes. If you look at women, all right, most of them don't develop osteoporosis till postmenopause. And that is because their estrogen levels drop. Now, we don't have ovaries to produce estrogen. Most of our estrogen, as Dr. Grant reverted to last week, comes from aromatization, whether it's systemic or whether it's, in particular organs. We need this for bone mineral density. We need this for muscle, for heart health, for contractile health, for brain health. All of these things are essential. And the only way we're going to have that proper androgen to estrogen ratio is with optimal testosterone levels. So oftentimes you're not necessarily going to feel tangible side effects as you may think, but that does not mean that you're optimal. And on the flip side, when you do optimize, oftentimes you will feel better, but even if you don't, it doesn't mean you're not garnering some of the benefits of optimal testosterone, which you're not going to be able to, have tangible access to today, but they are going to enhance your life and give you longevity. So just a little note on that, because a lot of times guys will start, and you see it on the groups, they'll come in, hey, I took my second injection today, or I've been using the creams for a month. I'm not really feeling better. I'm considering coming off. That's not how it works. This is not like a cup of coffee and boom, I feel energy. Guys should over the age of 35 get proper, and I'm going to go over the panel. I'm actually going to give a lot of information here. I've trained a ton of physicians, mid-levels or nurse practitioners, PAs, physicians, on how to manage testosterone correctly in patients. I've done that actually prior to even getting involved in my own clinics. And this is for the sake of unifying this industry to be done correctly. Okay, this is because I see harm being done to men, and it's not intentional. Medical practitioners take an oath to do no harm and to care for their patients. The problem is when they're not being taught correctly, and I tell you, this is not taught in medical schools and nursing schools. You don't learn this end of endocrinology. This is kind of like new to modern medicine. So it's important that guys understand to take it upon themselves and ask for the correct testing to be done. I'm going to give guys here all of the panels that I recommend for a fresh patient coming in. So guys should get tested periodically over the age of 35. Okay, if not once a year, every other year, you should get tested, and it should be tested correctly. Not at your primary if he doesn't understand what panels to run. It's not just total testosterone or maybe total and free, or maybe estrogens, it's not that. I'm going to give you the panels, but it's important. So once you have made the decision, go get tested. Now you're coming in, take it from here, Danny, and you tell me what questions you have and how I can educate you on testosterone and what sort of therapies are available.
Sure. Okay. So guys, anyone that just started watching it now, I'm a patient, headed to a clinic, Gil's there, other doctors there, I sit down, they say, Mr. Bossa, nice to meet you. My God, you are a good looking man. I say, thank you. And then they say, why are you here? Well, I can't say. I've been feeling myself for some time. My wife has noticed it. My kids have noticed it. My friends have noticed it. They say, you don't look that same happy self. Nothing really in my life has changed. I just don't feel the same. And it's weird. I don't feel like I'm depressed. I just feel like I'm off. I have a great relationship with my life. I love my wife, but I gotta admit, it's my wife. I love her. I'm embarrassed to say this, but I don't have that same drive that I had to lovemaking and all this type of stuff. And she always asks me if it's her, and she looks fantastic. And I think part of the reason why is I'm having issues with erections, so it's like, what if I start and then it doesn't go up, and it's so embarrassing.
So you're throwing all the symptoms in that bucket.
Yeah, I'm going to throw all the stuff in. Yeah.
Maybe one or two. It may not even be anything. It may just be like, hey, look, I'm 40 years old and I don't know, I've never been tested and I feel fine. But if I stop and think about it, I don't feel like I did 15 years ago, but let me write that off to aging. I mean, I shouldn't feel like I'm 25 when I'm 40, right?
Yeah, but I can come into this as a number of different patients. I can come into, I'm 40 and I don't feel my best. I can come in as the guy that I was just saying of, my libido's off, my erections are off. I just kind of, I can come in as, I'm training a lot and I feel like I've lost a bit of edge.
Here's one quick thing I want to, can you still see me on the screen? Because I have to take a slide here. Okay. So I'm going to read to you something called an ADAM score. ADAM is basically a androgen deficiency in aging males. It's short for that. It's an acronym. So the ADAM score is something we have all patients fill out in the waiting room. And if guys watching this video want to Google for the ADAM questionnaire or the ADAM score test, you could do this at home and just kind of see what your score is. It's 10 questions. And guys don't even know they're taking a test when they're sitting in the office. But these 10 questions give us an idea of their symptoms, and it gives us an idea, combined with their age, even before we get their labs back, gives us an idea of what sort of issues this patient is having so that we can discuss treatment approaches and ultimately find symptom resolution, because that's what it's about, right? It's about symptom resolutions and not just making the labs look good. So it's 10 questions. And the way this test works is simple. If you answered yes to number 1, or you answered yes to number 7, you're a likely candidate for testosterone therapy. Now, if you answered yes to 3 or more of any of these, you're a likely candidate for testosterone therapy. So real quick, I'm just going to go through the 10 questions, and that's going to outline to guys what it is. And if these relate to anything that you're experiencing, it's going to make sense to you. So number one, remember, number one is a key question here. If you answered yes, that in and of itself is sufficient. Do you have a decrease in libido or sex drive? Have your desires decreased? Okay. It's a yes or a no. Number two, do you have a lack of energy? Now, I know this is broad and this could be day to day, but this refers more to, you know, kind of a long-term decrease in energy. Not, well, I didn't sleep well last night, so today I don't feel good. But overall, do you notice a lack of energy? Number three, do you have a decrease in strength and or endurance? Number four, have you lost height? Okay, and this is important as well. Number five, have you noticed a decrease of overall enjoyment of life? Okay, is your mindset turning for the worse? Are you looking at things less optimistic than you used to? Number six, are you sad or grumpy? Okay, and I would even throw the word depressed in there. Do you feel mildly depressed more often than you should? Number seven, are your erections less strong? Or is the firmness decreased? Is the duration decreased? Are you losing them at some point, you know, prematurely? And then again, number seven is another one of those precursors where that in and of itself is sufficient. And then number eight, have you noticed a recent deterioration in your ability to play sports? Okay, and this refers more to recovery and performance. Number nine, are you falling asleep after dinner? And then number 10, has there been a recent deterioration in your work performance? And this one is more about cognition. Are you doing less at work? Are you kind of, you know, daydreaming in the office, not really having an easy time focusing on tasks? Is your attention being shifted and whatnot? So all these questions here, part of the Adams score test, help your provider, if they're using this correctly, to kind of diagnose and assess your situation before your labs even come back. And this is an opportunity when you're in that office on that initial visit to have that conversation. And then begin your education process based on what your particular symptoms is, because it's very individualistic. So Danny, you've just completed this test. Irregardless of what your results were, I would venture to say that most guys over the age of 35 that we have seen have at least 3 or more yeses, and I've seen straight yeses down the line on all 10 quite often.
Gotcha. Okay, so let's choose you know, what type of patient you'd like.
The typical ones that we see, because we focus on sexual dysfunction, and again, sometimes they'll say, yeah, I'm depressed, or my energy, but most of them tend to find us because of sexual dysfunction. So it's usually an erectile issue and it's usually a libido issue. Those are the ones we experience the most often in my particular situation in our office. The first thing I like to ask a patient, just to kind of gauge their knowledge level, is, do you understand how testosterone is produced in the body? Some say no, and some say, yeah, in the testicles. And, you know, they have some sort of, I guess, an inkling about that, but they don't quite understand. So testosterone is interesting because it is where your endocrine system meets your reproductive system. They kind of intertwine in the production of testosterone. Your HPTA, which is your hypothalamus pituitary testicular axis, also can be referred to in the form of hypothalamus pituitary thyroid axis, because your thyroid's involved in the metabolic effects of producing hormones through the HPTA. But we're not going to get into thyroids, even though this does play into some of the stuff in the office, which testosterone can help regulate as well, and vice versa. But your HPTA, your hypothalamus releases something called GnRH, which is a gonadotropin releasing hormone. And that stimulates your pituitary to release a hormone called LH, or luteinizing hormone. Luteinizing hormone gets into your bloodstream, travels down to your testicles, and activates the Leydig cells on their LH receptors. And what this does is it focuses on the Leydig cell production of endogenous testosterone. In layman terms, it tells your testicles, go ahead and produce testosterone. Right next door to your Leydig cells, you have something called Sertoli cells, and those are responsible for producing sperm. Your pituitary sends down a follicle-stimulating hormone for sperm production. Now, for sperm production to occur efficiently, there must be testosterone production intratesticular. This means that your endogenous test production must occur in your testicles. When you're taking exogenous testosterone, that does not suffice for proper spermatogenesis. And this is why we often find that exogenous testosterone reduces fertility or sperm count. Doesn't make you sterile, but it will lower your sperm count. And we'll get into that later when we discuss HCG. But Your LH activates your Leydig cells. You produce endogenous testosterone. This is released into your serum or into your blood. It travels through your body. Some of it is bound to a protein called SHBG, a sex hormone binding globulin. Typically up to 98% of your total testosterone is bound. And then the 2% remaining, ideally, if your SHBG is in a proper range, is what we call free testosterone. Free testosterone is what is effectively going to offer you symptom resolution. Example, I had a patient in one of our North Carolina offices, and he was on creams. And at the time, prior to me getting in there, they were running total testosterone and a couple of other tests. They were not checking for free testosterone prior. And one of the physician assistants there calls me and he says, look, I got this guy in the 900s and he's got no libido. What's going on? So I had him run DHT and I had him run free T. And his DHT was in the moderately mid-range, slightly to the lower end, but it didn't seem too concerning. His free T was single digits. His SHBG was well over 100. Okay, so I explained to him how we can lower his SHBG, which is something we discuss with patients about methods to doing this with therapy and frequency. But the issue was his free testosterone was not present. His testosterone was handcuffed by all this SHBG floating around. And they didn't understand without running the free T what's going on. So this is a classic example of trying to manage this correctly and why it's often done incorrectly, because you'll go to your primary physician and they'll check off total androgens on the LabCorp quest sheet. And that comes back with serum testosterone levels, and you'll come back in a 500. And they'll say, well, the range is 250 to 950. You're good, you're normal. Have a nice day. Go figure out what's wrong with you. It's not testosterone. But they haven't really checked it correctly. And then I know we spoke in detail, and I won't go too far into it last week, on the lab ranges, which are completely flawed, okay, because they're derived from a population pool of symptomatic or quote unquote sick men who go in for testing. So just because you're normal, just because you fall into a range does not mean you feel well, because again, it's individualistic. So your free testosterone is something that is extremely important, and that's what we shoot to optimize. And now that you understand how testosterone is made in the body, it's important to understand why it starts to diminish with age. So there are two types of low T, and the medical term for low T is hypogonadism. Okay, gonads meaning your testicles, and hypo is the medical term for low. Okay, hyper is high, hypo is low. Hypogonadism is a low state of gonadal activity, essentially, or low testosterone. This can be what we call primary or secondary. Primary means the primary organ responsible for production is failing. That would be our testicles. Secondary would be the pituitary gland or brain function, which is sending that luteinizing hormone signal. So if you have secondary hypogonadism, you're essentially not stimulating your testicles properly. And if you have primary hypogonadism, the stimulant is going down, the testicles are non-responding. It's like poking a dead horse, right? It's not gonna do anything for you. Why is it important for us to test if you're primary or secondary? That diagnosis is crucial, and you only get one chance to do it, and that is before you begin therapy. When you begin therapy, this is what's called a closed feedback or a negative feedback system. Negative feedback means that when one hormone increases, the other one decreases. Okay, it's a loop. So your luteinizing hormone goes down, testosterone is produced, some of it aromatizes into estrogen, and then that estrogen binds to estrogen receptors in your brain and turns off the faucet, telling the luteinizing hormone, we got enough, cut it off. When your luteinizing hormone is low, and we test it in an optimal time period when it should be peaking, your luteinizing hormone is low, this is telling us that your testosterone production is not being stimulated properly. So the issue is up top, it's upstream. When your luteinizing hormone is high, yet you're still showing a deficiency, this is telling us that the issue is primary, it is downstream. And the reason it's important to diagnose this up front, and again, you only get one shot, is because the treatment option may vary or differ, especially with a younger patient. We may try something called a kickstart. Okay, a lot of younger guys have had concussions or head trauma or radiation, or something that is causing them, even stress at times, can cause your gonadotropin levels to decrease. And if we can identify this early, but your testicle function is sufficient, we may, depending on your age and your plans for the future for fertility and whatnot, we may try to kickstart your brain activity and your hypothalamus and pituitary to release more gonadotropins so that you have a fair shot at producing endogenous testosterone rather than reverting you to therapy prematurely. Okay? Even if you're going to end up on TRT, right, testosterone replacement therapy, we know that we can add in a gonadotropin mimicker, like HCG, human chorionic gonadotropin, which is going to mimic the LH in your body and allow you to produce a little bit of endogenous testosterone to maintain your fertility level, maintain testicular size and prevent atrophy, maintain ejaculate volume. It increases penile sensitivity, okay? It increases libido. There's a lot of benefits to this. But if you're a strong case of primary hypogonadism, which is often common in older men whose Leydig cells have died and are non-responsive, this gonadotropin mimicker, or HCG, is not going to be as effective. And if it is, it's going to require higher doses. So this is why it's important to diagnose correctly. So on every initial baseline lab, you should request gonadotropins be tested. And this would include luteinizing hormone at the very least, and if fertility is an issue, FSH, which is follicle stimulating hormone. These are typically not tested at primary physicians, and they are important for these reasons. So that's the explanation on that, Danny. What other questions would you have?
Again, depends on the type of patient perspective you want. If you want to give me an idea of the type of patient I would be.
Well, sexual dysfunction is pretty common. As you could see from the groups, this sexual function is an important thing for men or all people. And you see that a lot of guys that come into the groups who are on T therapy or thinking of starting, they're usually complaining of some level of sexual dysfunction, right? So I think if we focus on those guys, we're going to cover a lot more of the masses than if we just stick to the performance guys.
Okay. So let's use the example that I was using before of, everyone was saying whatever, but I feel like my libido is off and my erections are off. And someone was telling me about this testosterone stuff. And, how is testosterone going to fix that? And how do I know it's that? What can I do to know it's that?
So with erections, which is right up our alley because it's about 50% of what we focus on in the clinic is erectile dysfunction and fixing that. So testosterone is not a magic bullet for erections. What this means is when you optimize your testosterone, it doesn't mean you're going to have 18-year-old erections all over again. But you have to consider why erectile dysfunction occurs. And when we say dysfunction, you have to understand any loss in erectile function is a dysfunction. It's not full out impotence. Just because you can achieve an erection or maintain an erection does not mean you do not have a form of ED. Is your erection as firm as it once was? Does it occur as quickly and as efficiently as it once did? And are you able to maintain the duration that is sufficient for you and your partner? If the answer is no to any of those, you have a form of erectile dysfunction, but don't panic. It is extremely common. From the latest statistics that I looked at, 40% of men over 40 have some form of erectile dysfunction. That's almost half, okay? And that number adds 10% for every decade. So it is not uncommon. Now, everyone always runs to the PDE5 inhibitors, the class of drugs known as Cialis, Levitra, Viagra, okay, the oral tablets. What these are systemic vasodilators. They produce a dilating effect in your entire body, which is why some people experience headaches from them. The nitric oxide that goes in there and allows the blood to flow is extremely important. The penis has two spongy tubes on the side called corpus cavernosum and one on the bottom called corpus spongiosum. When the cavernosums fill with blood, there's a lot of tiny little blood vessels in there, and then you have your main arteries. When they fill with blood and hold that blood, that is what produces an erection. Sometimes as you age, you develop something called a venous leak where the blood flow is inconsistent and it's a failure to maintain the erection. And sometimes there is an occlusion or a fibrosis where you have some calcification built up over time, and this can cause Peyronie's disease, which is a slight bend. It can be painful, definitely unsightly for some guys, cause some anxiety. That in and of itself can lead to libido issues. Because if you have anxiety, performance anxiety specifically, will I achieve an erection? Will I maintain my erection? This causes the anxiety to be severe enough where you don't even want to put yourself in that situation. And that in and of itself is going to cause stress around anything involving sex, and that's going to destroy your libido, right? So we fix these things in the office with various non-invasive procedures. But before we even get that far, we have to consider what caused this issue. So if I have a brand new vehicle, it drives meticulously and I keep changing the oil and I maintain it and everything's great. When that vehicle hits 100,000 miles, seals, gaskets, plugs, wires, brake lines, these things are going to start to wear and go, right? So what happens in our body? Our body is very efficient at reproducing cells as they break down. And testosterone is a recovery hormone as well, and it's responsible for that. Now, I often ask guys in the office who are 40, 50 years old, I say, I got a question for you. Let's rewind the clock 25 or 30 years. Did you wake up with an erection in the morning? And they would say, yeah, every day. And I say, how often does that happen now? And sometimes I hear it hasn't happened in years. Sometimes I hear once a week, twice a week. I say, would you say there's been a reduction in this? And they say, oh yeah, absolutely. Most of them don't realize you didn't just wake up with an erection. Guys experience nocturnal erections or nighttime erections 7 to 10 times per night. And they can last 10 to 15 minutes. So when you consider that you're spending 2 to 3 hours a night in an erect state, think of your penis going to the gym, right? If you were to spend 3 hours a day, lifting weights, your arms would be big and strong, right? But now you stop going to the gym and you only go 1 day a week. What's going to happen to those arm muscles? They're going to atrophy or shrink. They're going to lose stamina. They're going to lose their ability to perform. So guys always think of, well, my erections are there for sexual purposes. What they don't realize is the exercise of that region actually occurs in your sleep when your testosterone production peaks. So what do we experience with guys who start TRT and get optimized fairly efficiently is their nocturnal erections are back. Guys are waking up with morning erections once they're optimal on TRT, even at 60 years old, right? So it's important to note, why did this erectile dysfunction occur? It wasn't an overnight switch. It was the last 15 years of not realizing that you're no longer getting these nocturnal erections. So the blood flow there, right, has diminished. So when you cut your arm, why does the area turn red? Your body recognizes that it needs to heal, and it'll send blood vessels and new pathways into the area so the platelets could go in there and heal the wound. But once that wound is healed, what happens to that redness? It goes away. So those blood vessels are no longer needed. They get reabsorbed. Well, the blood vessels in your penis are not being utilized as frequently as they were because of the lack of nocturnal erections. So your body takes them back. You don't use it, you lose it. So when you're losing these vascular pathways over 15 to 20 years, when you need them, they're not there for you to perform like they used to. So again, we have procedures to restore those pathways. But the first, token of business is fix the issue, the underlying cause of why this happened in the first place. Bring your biochemical hormone balance back to where it should be, so that once you fix the issue, it doesn't happen again. And obviously your libido and performance returns. So from a sexual function issue, testosterone is extremely important, but it is not the end all to fixing the issue. It is the underlying cause. And once you understand why it happens, you fix that and then you build up from there.
Gotcha. We could use the perspective of a different patient that comes in and says, I've been, working out my whole life and I eat well and I'm always active and I'm training, 5 days a week at the gym like I have for the last 20 years. And for some reason, last 2 years or so, I just, no matter what I do, I feel like I'm losing mass, if anything. If anything, I'm getting fat, and I've dialed in my diet even more than before. And it's like something's off.
So metabolism is broken down into two categories: anabolism and catabolism. Anabolism is the state of whereby you're taking micronutrients, okay, or molecules and building up from there. So like amino acids converting into protein or into muscle fiber is anabolism. Catabolism is where you're taking the larger molecule and breaking it down into its simpler form. So everyone knows that testosterone is an anabolic hormone. It promotes anabolism. It promotes nitrogen retention. So it does things that are going to help you build and maintain lean mass. And when you have more lean mass, your base metabolic rate is elevated. And therefore, this allows you to break down more energy in the form of fat, right? Your fat, your stored energy is basically there to use later. It's an emergency fund, so to speak. And the more lean muscle you have, which is why I tell guys all the time, you want to lose weight, focus on resistance training, build lean mass. Don't worry about cardio. You can burn 500 calories on that treadmill, go out, have a slice of pizza, and you just replaced it. Don't try to chase calories in the gym. Focus on building lean mass. Become an energy burning machine 24 hours a day. A guy with good lean mass can lay on the couch and watch a movie and burn more calories at rest than someone without lean mass is going to burn by 3 hours in the gym. Become an energy burning machine. Take that 4-cylinder, make it a V8 twin turbo, right? And then you don't have to worry about how many calories am I burning? What did my Fitbit say? How long was I on the treadmill? Don't worry about that stuff, all right? Bodybuilders don't really do cardio in the off season, yet they still maintain a level of lean tissue that is visible. And that is because they have so much lean mass. I'm not suggesting the layman folks go out there and become bodybuilders, but they sustain so much lean mass that it would literally be difficult for them to gain fat unless they literally ate cheesecake and pizza all day. And they're eating 5,000-6,000 calories a day, and they're not putting on body fat, right? So maintain a state of an anabolic environment, and testosterone will certainly help you do that. And we know this. I mean, guys when they start testosterone therapy, all of a sudden their androgen to estrogen ratio balances out. Their appetite generally increases, so does their energy. They start hitting the gym more, they sleep better, they recover better, and they start making more conscious decisions because they're now more in tune with their health and their body. And the first thing we notice is a reduction of visceral fat around the belly, or mental fat. Their waistline starts to shrink, their upper torso begins to grow and strengthen, and this is completely reversible at any age, okay, which is the beauty of this. We know that cancer patients and HIV patients who have very catabolic syndromes and take a lot of medications that are promoting catabolism, they use testosterone to prevent muscle wasting, right? We know some of the DHT derivatives like oxandrolone and stanozol, these were prescribed specifically to treat muscle wasting diseases and burn victims, for example. So these hormones have very strong anabolic properties, and they're going to help you sustain lean mass and build more, lean physique. So definitely for the performance guy, I mean, this is a given. Again, we're looking to put you in physiological ranges. If we're slightly above what they call normal in the lab ranges, that's okay, so long as we achieve symptom resolution and we're not causing harmful side effects. And again, it's very individualistic. I know guys who at 850 get terrible anxiety and they need to be dosed down. And I know guys at 1500 who feel like they're on top of the world and they have no detrimental side effects for years. So it's not a one-size-fits-all number, and you can't be married to a range. And I know a lot of physicians panic if you're flagged on the high end of your total testosterone, and right away they say, whoa, we're going to take you off, or we're going to cut your dose down. It's not how it works. So all of this stuff we discussed so far is pretty much symptoms, mechanisms of production and whatnot. What I think we should really get into, which I think a lot of people who are newer to this don't quite understand, and I've personally seen a lot of guys, both transfer patients who come in as well as guys who reached out to me, online and whatnot, they are being done incorrectly. They are being put on protocols that are completely wrong. And why don't you give me a couple of questions or maybe you came in and you're already on testosterone from your primary or your endo. Give me a type of a protocol or a dosing scenario that some of these guys may be on, and let's break down why it's incorrect and why it may actually do you more harm than good.
Okay. So now I've become a totally different patient. I come to see you and I say, Master Gill, I've been seeing an endo for last 6 months, and I don't think he knows what he's doing. I don't feel well. And I keep telling him I don't feel well, but he says he's doing it by the book. And you're like, well, what is he giving you? Well, I have to go to his office once a month, and he gives me a shot of 400 milligrams of testosterone once a month. And he says that over the course of the month, it'll kind of fall gradually. And then by the end of the month, he'll give me another one. And, right. The first week, I feel like pretty good. Second week, it's like, but then the last 2 weeks is like, they kind of suck. And the last week, it's like, I kind of want to jump off a bridge.
Right.
What am I doing wrong? Or what is he
Or we could also say he's giving you 400 every 2 weeks, or he's giving you 200 every 2 weeks, or he's giving you anything every 2 weeks.
Right. Yeah.
So here's the
problem.
problem.
A million examples we can give.
I'm going to give you the real easy analogy to understand. And I ask patients this all the time in the office. You ever have a headache before? and taken a
Sure,
Tylenol?
married.
Well, have you taken have you ever taken a Tylenol to resolve headaches?
Yes.
Okay, the next time you take Tylenol, Danny, what I want you to do is I want you to take the whole bottle. And now we just ensured you're not going to have a headache for the next 6 months.
Isn't that bad?
Well, you'll die from liver toxicity, but that's besides the point, right? If you're taking 2 Tylenol to resolve a headache today, why wouldn't taking 40 Tylenols fix headaches for 6 months?
Right.
Why?
Because it's only going to have an effect for right now.
Right. So if you're eating breakfast, lunch, and dinner, why don't we eat triple breakfast and then skip the rest of the day? We're still consuming the same amount of medication or the same amount of food. Why can't we just front load it and take time off? That's not how metabolism works, right? You can't front load medication because medication has something. This is pharmacology 101. And I know that most people haven't taken pharmacology courses unless they're in the medical field. But what troubles me is that when you have physicians who have gone through medical training and they've taken various pharmacological courses and they understand mathematics and they understand half-lives. The half-life of a medication is very simple. I'm going to break this down to the simplest form possible. I give you 100 milligrams. How long does it take before 50 milligrams remain in your system? 50 is half of 100. How much time has elapsed until we hit that 50-yard line? And the answer for the testosterone ester, and an ester is a molecule attached to the medication that determines the time release, okay? The ester used in the United States most commonly is cypionate. So testosterone cypionate, testosterone attached to a cypionate ester, generally, depending on your rate of metabolism, which differs slightly from patient to patient, is going to have a 7 to 8 day half-life. This means in about a week after that injection, 50% of the medication remains in your system. A 400 milligram injection has 200 milligrams remaining. A week later, there's 100 milligrams remaining. A week later, there's 50, and a week later, there's 25 from 400. So every 7 days, we're cutting it in half, okay? Here's the problem. An average healthy male produces 7 to 10 milligrams of testosterone or equivalent per day. Now, if you calculate that out, that's 60 to 70 milligrams per week. What do you think is going to happen when I inject you with 400 milligrams at the time? This is similar to me saying take 40 Tylenols today. There's detrimental side effects to that. That is an overdose. Now, you don't overdose on testosterone. It's not a narcotic, it's a hormone. You don't overdose on it in the general sense where you're going to go into convulsions, fall back, vomit, and die, okay? It's a hormone, but it will have side effects that are unintended. They could be anxiety. They could be spillover into metabolites. They could be erythropoiesis, which is the elevation of hemoglobin and red blood. There's a lot of things that are associated with testosterone as negative. And a lot of that is undue, and it's only there because of the mispractice. And I say mispractice, not malpractice, because I want to use that word very carefully. It's being practiced incorrectly by a vast majority of providers, and it is a shame. And I'm not doing this to shame providers. I'm doing this because it's a shame that it's done this way, and it shouldn't be. So when you take a medication with a half-life of 7 days, and you tell someone to dose it once every 14 days, let alone every 28, you're guaranteeing that this individual reaches the 25% mark from where they began. Now, what do we want to find in a medication, let alone a hormone, which balances our well-being and our state of mind? We want to find homeostasis. We want to find a comfortable flat line, a steady zone. If this makes me happy, do I want to be happy all the time? If this gives me good energy and libido, do I want to experience this all the time? Or do I want to go from high to low to high to low? Isn't that type of rebound what drug addicts go through when they take their drug and then they crash and they go out for the next fix? Why would you want to treat a patient in that sense of putting them on this seesaw effect of highs and lows and highs and lows? Why do you want to make a Jekyll and Hyde out of an individual that comes to you suffering from depression and erectile dysfunction and all these other slew of issues and symptoms? Why would you put them on highs and lows, let alone the other side effects of overdosing with a single administration? Why not?
It says that on the vial as well in many cases. The testosterone I have says ideally is 200 milligrams every second week.
The
So
problem is
even
with
the
the name.
pharmaceutical companies making this stuff are
Yeah,
getting it
this is
wrong.
the name brand. This is the name brand ones, and this is stuff that was written back in the 90s and never been changed. We actually ship patients from a compounding pharmacy. So we are the ones, my providers are the ones that determine the dosing and put the instructions on their label. So ours, for the most part, for guys that start, will say administer 0.25 or 0.3 of an ml, which is equivalent to 50 or 60 milligrams twice per week or every 3.5 days. So here's what I'm doing. You ready? I give you 100 milligrams, and I use 100 for simplicity. It's going to be dose dependent on the patient. I give you 100 milligrams today. Day 7, you're at 50. No good. I don't want you to feel half of where you felt earlier. Not terrible, but I don't want you to get to the halfway point, okay? I give you 100. On day 3.5, you're at 75. I'm retopping you. You're going down, I'm retopping you. You're never dropping below that 75% mark. When you're between 100 and 75 at all times, you're averaging about 85, 87% of where I want you to be. Your high is going to be higher than if I yo-yo you up and down every other week or even once a week, right? Not only that, it's better for us to control all of the potential side effects because I know where your levels are all the time. You come in for labs, I don't care when your last injection was. You're never going to be off by more than 100 points. You don't have highs and lows. You're pretty stable. Now, I know that in our group, okay, a lot of guys favor the daily injections, microdosing, or every other day. And that's great too. Again, adhering is one thing because not everyone's going to adhere to that type of a schedule. But it is certainly something that's going to help you stabilize the hormone better. Twice a week with cypionate is plenty. It's sufficient. Another problem is that most providers will teach guys how to inject in the glutes with a 22 gauge, 1 inch or 1.5 inch needle. It is not needed for TRT, guys. This came from the old steroid world in the 70s and 80s where guys were doing 2 to 3 cc's per compound, per injection, 3 to 4 times a week. Okay, they're running a lot of oil through this. So they needed the 3 cc syringes with the big needles. Not needed for TRT. I have a video up, which I could share with you, Danny. I think I put it in the group previously. It is an injection protocol using a 27 or 28 gauge half-inch insulin needle. This is the same syringe that guys are using for diabetes, for insulin. Okay, diabetics may have to inject Humalog or Novolog, which is a rapid insulin, 2 or 3 times a day. Okay, 4 times a day. Twice a week is nothing. It is non-invasive. There's no pain. There's nothing. You can't even tell if you don't look. All right, and we teach them how to use them in the delts or in the ventral glute, which is the side of the hip. And there's no blood, there's no nerves, there's nothing, you can't feel it. So guys are using minimally invasive techniques. They're doing them at a frequency that is correct, and they're never experiencing these highs and lows. I hear all the time. Just last week, a guy that I know for a long time reached out to me and said, hey, got to ask you a couple of questions. And in the discussion, this was more about training. And in the discussion, they got to, well, I started TRT with a doctor locally, and I asked for dosing frequency and protocol. 450 milligrams every other week. And it blew my mind. And I try to have the conversation, but he just didn't want to hear. He said, no, I'm good there. I'm good. I feel good. Well, of course you feel good. You're on a steroid cycle. How long do you think you're going to feel good for? How long do you think you're going to stave off the side effects of 450 milligram injections, right? And he's not a big guy. He's $160, $165. You know, and it blows my mind at how, and I know why it's being done. I mean, some guys do it out of ignorance because they genuinely don't know. So they should get some education on it. Some guys do it because they're an insurance-based clinic and the only way insurance is going to pay them is for an office visit. And they know they're not going to drag you in there twice a week. Who's going to go to the doctor's office twice a week? But if they tell you come in twice a month, it's a little more manageable. So every time you come in, they hit your insurance for $175. And you know they're getting $350 a month out of that patient's insurance, and they just keep them on twice a month protocol. Disservice to the patient, but it's a business decision, and it's a shame. If you prescribe the vial for the patient to take home, and teach them correctly how to administer, self-administration should be done twice a week or 3 times a week, and the difference there should be determined based on SHBG, erythrocytosis, and how the patient feels overall.
Makes sense.
Right? Frequency is big. That's where it gets screwed up most often is what I see.
What would you say would be side effects that guys would get doing these kind of higher doses like that? Side effects and
anxiety, for starters, anxiety. High injections like this will crush SHBG, sex hormone binding globulin, right? The one that binds to your testosterone. This will shoot free testosterone way up. I mean, you're taking a 450 milligram injection. I don't care how often. You're taking that injection 2-3 days later. I mean, your free testosterone is well over 100. And just to give guys perspective, we shoot to get patients between 25 to 30, 35. I mean, 25 to 35 is a sweet spot that we found with hundreds of guys where they tend to feel the best. Your free T is going to be 150 to 200 on that type of a dose. So anxiety, insomnia, irritability, aggression. I mean, when I say aggression, I'm talking picking fights with anyone and everyone over everything. Okay, this is the quote unquote, and I hate to use the term roid rage because it gives it a bad name, but this is where it comes from. It doesn't come from the medication. It comes from the abuse of the medication. Everything can be abused. There is use and there is abuse. And the only change there is frequency and dose. That's it. Everything can be abused, right? You can take things that you enjoy and even things that are good for you, and you can abuse them. And when you abuse them, look, having a beer on a Friday night over a football game with your buddy is not a big deal. Having 3 bottles of vodka on a daily basis is an alcoholic. They're both alcohol. What's changed is frequency and dose. Testosterone is no different. You frequent
Guys,
it and dose it incorrectly.
For those of you wondering what he meant by the 25 to 30, that's a measurement in what's called nanograms per deciliter. So if you look on a lab chart, it'll say NG/DL, just so you know what type of a unit of measurement we're using here.
Good point. And one thing I want to notate, Danny, which I don't even know if you're aware of. I know Dr. Grant's aware of this because we discussed it previously. LabCorp still reports
yes,
3 T in picograms per milliliter, but they're giving you the nanogram per deciliter number. They just have the wrong unit listed. And I had a call with their medical director over this, and they acknowledged it, and they haven't changed it. And this is months ago. So if any of you guys are using
people that have called in.
If you guys are using LabCorp, understand that your free testosterone result is being reported correctly in nanograms per deciliter. However, on the column on the right, it will say PG/ml, which is picograms per milliliter. They are using the incorrect unit on their lab, but they're reporting it in the right number. So it's just a confusion, and I can't fathom why a company like that would not fix this issue.
This doesn't seem like that big of a deal to fix. Because I get guys emailing me like,
my
labs are 30, which means I got a free T of 3. Like, wow, I feel pretty good.
Some countries outside the US use picogram per milliliter. And they will basically have to down convert a 10 to 1. So 30 would be 3, and a free T of 3 is terrible. And it's like a 90-year-old. It's like an unhealthy 90-year-old. So guys are freaking out, but it's incorrect. So and LabCorp is the only one that I've noticed that reports that way incorrectly. But yeah, nanograms per deciliter, it's nice to maintain total and free in the same unit of measurement so that you can calculate a ratio. Mm-hmm. So again, I don't understand why some labs would use different metrics and different units, but 2 to 2.5% of your total testosterone is where you want to land on your free testosterone for optimal ratio. Why? Because this tells us your SHBG is in a moderately good range. And it is important. And I know you did a video with Broderick Chavez the other day, I think yesterday, in fact, where I haven't watched the whole thing yet, but I saw some commentary on it where SHBG was discussed as to why it could be important as well. And guys always have this misconception of the lower my SHBG, the higher my free T, the better. Let's crush it, crush it, crush it. Mm-hmm. And that's not the case. And it's evident with diabetic patients or pre-diabetic insulin-resistant patients. We often notice SHBGs in the single digits. And that is terrible because, again, their libido suffers, their longevity and their optimal health will suffer. 30 to 40 SHBGs, really nice and sweet spot. And then the other thing is albumin. A lot of guys don't understand the difference between bioavailable testosterone and free testosterone. Albumin is another protein. There's 2 proteins that bind T, albumin and SHBG. Albumin-bound protein is considered bioavailable. So if you guys ever see bioavailable on your lab, that is not free T. That is free T plus T bound to albumin. Together they make a bioavailable. Why is it bioavailable? Because your body can still utilize it. It just has to work for it. Free T is free. It's there for the taking. SHBG bound T is not free. Albumin bound T is bioavailable. So there's a distinction. Bioavailable.
Go ahead.
No, that's it. Just
let's throw one last patient question that's probably going to come up. Okay, so I'm the patient. I've been looking up this testosterone stuff. You type in testosterone, and I wound up all these bodybuilding forums, and I'm learning about testosterone from the bodybuilding forums, and they're saying what guys are doing, and they're like really afraid of this thing called estrogen or E2, and they say that any doctor I go see, if they don't give me something to block it, I should run for my life. So what do I do? Because I don't want to have this estrogen E2 stuff in my body, because apparently I'm going to grow boobs and I'm going to cry at sad movies, and I'm going to become like more close with my wife and stuff. Like, I don't want that. So
guys, understand, you're a man. Estrogen is the devil. It's a female hormone. You're going to get high blood pressure, edema, irritability. You're going to grow man boobs, and you're pretty much going to be PMSing all day long. So crush your estrogen as much as possible. 5 milligrams a day of an estradiol in the morning, 7 milligrams before bed, and you're guaranteed to bring your estrogen to 0. Don't forget. All right, so here's the deal.
I took 2 milligrams a week for 1 week. Oh.
Yeah, and when you did push-ups, you heard creaking, right? So we hear this on the bodybuilding forums all the time. Estrogen's the devil, right? Everything's blamed on estrogen. Ironically enough, if you really understand the science behind this, estrogen is one of the greatest benefits of testosterone. Remember, women need testosterone. Men need estrogen. We both need both, but we need different ratios of them. Now, I credit Dr. Grant with this, or at least bringing it to light, within the groups, and at least educating me on it. I always knew that estrogen is essential and it's important because I've researched it, and I've never used aromatase inhibitors with our patients in our clinics. Our providers have never prescribed them to people, at least not since my tenure there. Blocking aromatization is essentially telling your body, I don't want estrogen, because we don't have ovaries. We can't produce estrogen. We have to derive it from testosterone. It is a downstream metabolite of testosterone. It's converted over. So think of testosterone as the ingredient. You can't make bread without flour. Okay, so if I take away your flour, you got no bread. I need aromatase enzyme acting on testosterone in order to convert into estrogen. Estrogen is responsible for bone mineral density. It is responsible for libido. It is responsible for erectile function. It is responsible for building muscle. Okay. Why do you think bodybuilders use estrogenic compounds in the off season when they're looking to bulk mass? Okay, don't let the word bulk scare you. It doesn't mean getting fat. It means putting on more muscle. Okay, you need estrogen. You need estrogen to regulate metabolism. You need estrogen to lose fat. You need estrogen for your heart, your brain. Okay, all of these things are extremely important. And when you're blocking the very pathway by which estrogen is produced, you're causing harm. Your synovial fluids in your joints are going to dry out. You're going to have pain. You're going to get irritability. You're going to experience heavy depression, and I mean heavy. I don't mean like I woke up in a bad mood. I mean suicidal thoughts on guys using, high doses, which is another reason I don't like Clomid, but that's for another video. Clomiphene citrate, terrible medication that a lot of providers use to treat secondary hypogonadism. I dislike it, and I actually have a 9-minute video just on that. Estrogen is important. Okay, Dr. Grant brought to light recently, just last week on the video, a long explanation about how it is a paracrine hormone. Paracrine means it acts in and around, or around. Intracrine acts intracellular. Paracrine acts around a specific organ. Every single organ that estrogen is utilized in is responsible for some level of aromatization. He expressed that from recent literature he's read, your testes are only responsible for about 15% of aromatization. The other 85% comes from other organs, okay? Your liver, your kidneys, your prostate, these all aromatize estrogen as well. And the estrogen concentrations in those organs can be 20 to 100 times more than what your serum level shows. So when you're testing estradiol, okay, there are 3 estrogens, estrone, estriol, and estradiol. Estradiol is E2, it's the second one, it's the most potent. When you're testing estradiol serum, even the ultrasensitive, you're testing the serum level, how much is floating around your blood. You're not testing the paracrine because you cannot test it. So therefore, you're coming up with a number that is moot. It is essentially what the spillover is, okay, how much leftover. So if I'm carrying a tray of hot dogs and I got 500 hot dogs and I'm walking to the barbecue and I drop 2 on the floor, you're testing the 2 on the floor and tell me you got too many. Well, you don't know that, okay? This is the spillover into your plasma. So it is really moot. It is a self-regulating system. It's part of your endocrine system that is self-regulating. If you feel you're experiencing an imbalance of androgen to estrogen ratio, you can adjust your dosing accordingly. More often than not, what I'm noticing is it's too much free testosterone that is causing these quote unquote estrogen symptoms that guys complain about. So if your free T is too high, perhaps have a look at your SHBG, have a look at your total dose, have a look at your frequency, okay? And adjust your TRT protocol accordingly. You do not need aromatase inhibitors. Gynecomastia, I spoke about last week, requires genetic predisposition to developing gynecomastia, requires elevated IGF-1, insulin-like growth factor. This is a precursor to growth hormone. It requires an elevation in that. It requires progestin, and it requires an imbalance of estrogen or androgen to estrogen. And you'll usually find gynecomastia is more prominent in guys with low testosterone. Why does it happen in bodybuilding? These are guys coming off cycle. These are guys with an androgen tanking. Doesn't happen on cycle. This is why in their PCT or post-cycle therapy, they're using SERMs like tamoxifen, right? Novadex. It binds to the estrogen receptors in the mammary gland. Specifically, it's localized. And it will prevent activation and gynecomastia while their testosterone is tanking until they can recover from their kickstart. So this is not something to be concerned over in TRT patients. And like I said, we have a couple thousand TRT patients. No blockers, no aromatase inhibitors. Okay,
that is one thing I can add to that, guys, is when you're looking at your labs and you're looking at your number, you're concerned with that number based on what the clinical range is for estrogen and in picograms per milliliter. That ratio that we tend to see on these labs is 20 to 30. You have to understand that this 20 to 30 is the range that is taken from a population of people that are not on TRT. So just the regular people not on TRT, oftentimes it was falling in around there. And even then it's up for debate because we think that it was actually taken from one single study.
These are low T guys being tested.
Correct. So because these people, typical population, we see the testosterone continues to drop. The estrogen levels are dropping. They're in a relation to that low level of testosterone. Now, if you're bringing up testosterone because you're going to be on TRT, you have to understand that you have to bring this one up with it to keep that ratio. You don't just bring up one and then drop the other one down, because the bigger that ratio, the more issues you're going to have. There needs to be that balance between the two. The more you're going to bring up one, the more you're going to bring up the other. People think like, oh, if I'm going to keep going, my estrogen is going to go through the roof. There is a point that estrogen is going to stop. It's really not something to worry about. If you're a guy on TRT, that whole notion of the 20 to 30, throw it out the window. It is irrelevant. It does not apply by any stretch of the imagination. So do not be afraid of the number. Most of the docs in our group don't even measure estrogen or E2 anymore. We couldn't be bothered with it unless there's an actual deficiency where they don't have enough aromatase to actually convert enough testosterone to estrogen, and their estrogens are very, very low. Then it may be looked at, but typically speaking, it's just not even looked at it. It's not measured. It's not.
And just to touch on that, Danny, a lot of guys are also using androgenic compounds for performance basis, which act as an aromatase inhibitor, particularly the DHT derivatives. Okay, so without naming specific, performance drugs that guys would tend to use, some guys on TRT do take it upon themselves to use these underground labs to throw those in, and then all of a sudden you're coming back and your aromatase is inhibited, and your E2 is in the single digits, and you're thinking, well, what the heck's going on? I didn't give this guy any anastrozole. Why is he crashing? And then in conversation, this comes out. So that is another reason why we do test it, because they may be complaining of symptoms, and you're thinking everything is great, and then you're not aware that they're using other compounds because they rarely will tell you. But then when you check their estradiol, you're going to find this out. So that is why we do test it. We don't test it so that we can inhibit it. We test it so we can have a full, clear picture as to what is causing these symptoms that we're failing to resolve. And oftentimes it's guys adding things that they should not be adding. I want to leave guys with what I promised earlier, which is lab panels that they should be asking for, they should be running, and why. So as I said earlier, gonadotropins, LH-FSH, you should be running to determine if you're primary or secondary hypogonadal. You only get one shot at this. Once you begin TRT, they go essentially to zero because of that feedback mechanism. So make sure you get that up front. Total testosterone, needless to say. Free testosterone. Now, free testosterone, I'm not a fan of the calculated free T. I'm not a fan of the direct free T because oftentimes it is inaccurate. So what we do is we test total and we test SHBG, and then we use a calculator There's a formula. We use a calculator to figure out what the calculated free T is, because I know that anything bound to SHBG is not free. So it's easier to do it that way. Direct free T has been shown to be erroneous on many labs, but you do need to find your free T. That is what you're shooting to optimize. We also check CBC on new patients and on follow-up patients. On CBC, make sure you request the differential with platelets, okay? There's a big difference between erythrocytosis and polycythemia vera. Polycythemia vera is a state of elevated hemoglobin, hematocrit, and platelets, okay? Platelets cause coagulation. Without elevated platelets, you are not at risk. So thrombosis is something that needs to be checked. Differential with platelets is important. It's a $2 difference. If a guy orders for you a CBC without diff, they're saving $2 at the expense of managing your health. Make sure you ask for differential and platelets on your CBCs. PSA, very important. Why is PSA important? We already know that testosterone does not cause nor promote prostate cancer. In fact, quite contrary, testosterone actually can prevent the onset of cancer with aging. However, if your PSA is elevated, and by elevated I mean above 4 or significantly above 4, you should be referred to a urologist to rule out any existing prostate cancer. Guys, when they age, they tend to get prostate exams a little more often. They are somewhat invasive, and by checking your PSA with every testosterone test, we get 3 or 4 opportunities per year to kind of monitor the trend. I'm less concerned with the specific number. Look, if you're at 4, you're at 4, and if you're at 4 for 5 years, that's your number. But if you're at 4 today and you're at 12, 3 months from now, we're going to probably repeat that test. And then if it comes back consistent, then you're going to get a referral to a urologist. Make sure that you are abstaining from sexual activity for 72 hours before you go in. Make sure you're not riding a bike or a motorcycle for that time frame. Putting pressure on your prostate or ejaculating is going to elevate your PSA numbers transiently. It is going to give you a false positive. So very important. Drink water before you go in. If you're fasted, it's a little bit better. You don't have to be, but it's a little bit better. But drink plenty of water so that your blood flows. Oftentimes hematocrit will come back high because you're dehydrated. You haven't drank sufficient water prior to going in, and then the vein will collapse or the blood will stop flowing. So get yourself a bottle, 18, 20 ounce bottle, drink it within the hour before you go in for your blood draw. And then on follow-ups, pretty much the same testing. We may add prolactin in, especially if a guy's complaining of continued ED. Sometimes when prolactin elevates, double the normal range, you get into the 30s, you're going to start having issues. We have dopamine agonist medication that can knock that back down. So make sure that your provider is well educated on TRT. If they just follow the what I call cookie cutter approach, find a new provider, guys. Your doctor works for you. It's okay to get a 4th, 5th, 6th, 7th opinion until you find what you're looking for. Groups like this, like the one that we're posting in, are phenomenal resources. Not all groups are created equal. So be careful and ensure that you're in the right group. Ask the questions. And again, it's okay to tell your provider, I want to get a second opinion. And if their ego is more important than your health, find a new provider. Okay, we're all in this for optimizing men's health. We're all in this to continually learn from each other, to learn from experience. And not one person ever knows it all. So, I learn on a daily basis from our patients. I learn from doing this. I learn from guys in the group. And I just want to share that information back with guys who are on the fence and maybe new. And by all means, don't take what I say as gospel. Take it and research it yourself and make sure that you're doing the best for your own health. You're responsible for it in the end.
Give a shout out for your clinics, perhaps, if you'd like.
The best
I know
way
this
to
wasn't
reach
really
me,
the point of this video at all, but
I don't want to make a bias. I'll be honest with you. I mean, look, I could be reached via my nutrition. I have a nutrition coaching company where I work with athletes and common folks on body recomposition. Guys can reach out to me there if they have any questions. They can find me in the group, obviously, TRT and Hormone Optimization Group, right? And then they can reach out to me at www.nextleveldietetics.com. And they can get in touch with me through the website and email me there. And if I feel that they are a candidate for testosterone therapy, or if they want to discuss that further, I can direct them. We have 4 locations. I can direct them to our clinics. I don't want to promote business in these videos because that's not my intent. My intent is education. This is not a promo for me. This is not a moneymaker. I know you do this for passion, and I'm doing this to help the industry get better. I'm not doing this to line my pockets. If guys want to work with me or one of my clinics, they can reach out, but I don't want to publicize it in that fashion.
There you go, guys. So I didn't intend on asking him this. He did not ask me to ask this. I can assure you, I was pretty sure I said, let me just give him the opportunity in case, and you can see the way he replied. Because this is purely educational here. Gil, was great to have you on. I know we're going to be doing more of these, so you guys are going to be seeing a lot more Gil. Enjoy the rest of the day. Thank you very, very much for the talk. It was very informative.
Thanks, Danny. I appreciate you.